Can I have the lights off, please? After Rabbi's talk on critical aortic stenosis and HLH, we're left with aortic coarctation, and I will briefly illustrate you also some other abnormalities of the aortic arch. In the fetus, we are concerned with two types of aortic coarctation. We have just the shelf. This is an MRI angio. You see here a shelf at the isthmic level of the aorta. Or you may have a severe hypoplasia involving the whole of the aortic arch, of the transverse aortic arch that you see here. And here you see the two corresponding specimens. These are the fetuses. So we'll try to differentiate between the two, and we'll try to reach the diagnosis. First of all, historically, the diagnosis of aortic coarctation was made by looking at the longitudinal view of the aortic arch that you see here, and try to get the view with the three neck vessels and find out whether the size of the aortic arch was narrow or not. But then this was abandoned, and I show you why with the help of a volume. You see here, this is a multiplanar approach to a case of coarctation. Just follow me. I put the reference dot at the level just below the isthmic portion. And if you look at the longitudinal view of the aortic arch, this may be taken for quite normal aortic arch. Then you look at the cross-section view of the trivessel view, and you see that actually the size of the aorta is much smaller than the pulmonary artery, and you see where is the reference dot. So indeed, on the trivessel view, you have the suspicion, and this was indeed a coarctation, that this may be a coarctation. And the other issue is that since I put the dot here, you see with the coronal view, this is the ductus arteriosus continuing with the descending aorta, and this is the isthmic portion of the aortic arch, going onto the ductus arteriosus, which should be the other way around. Should be the ductus, we should insert onto the isthmic portion of the aorta. So this is why this type of approach is a bit tricky, and so this was abandoned in favor of the trivessel view. So nowadays, we get the trivessel view of the thorax, of the upper mediastinum, which is parallel to the four-chamber view and parallel to the transverse view of the abdomen, where you measure the abdominal circumference. And this is what you see. You actually get this type of modified view. This is Rabbi's original drawing. And you see here on grayscale that you get the right alpha tract and the ductal arch and the aortic arch here, a bit of the thymus. There was a third trimester baby with the thymus very, very large, the superior vena cava and the trachea here. And with the color Doppler, you can actually make it out the two ductal and aortic arch, which are similar sides, and the trachea is on the right of the two arches. And also with a posterior approach, you can have this kind of blue or red V shape. And both branches should have the same color to exclude ductus dependency. Can you switch off the light, please? Can we have the lights off, please? Okay. So, since it was very, very difficult to have this type of direct diagnosis evidence on a longitudinal view of the aortic arch, this was a shelf a lot of time ago that you see here. On the trivessel view, you can actually have this kind of approach. And you see this was the same case I showed you before, with the disproportion of the ductal and the aortic arch, or an even more convincing evidence in another case in which there was a significant prevalence Hello? Of the ductal arch over the aorta. It's a pity that in this case this was a false positive and there was no coarctation whatsoever in this case at birth. And so we should keep this in mind when we counsel the patient with the suspicion of aortic coarctation. Color Doppler, okay, we have disco tonight, disco party here. Yeah, just to change lights. So in comparison with a normal arch, you may have a significant narrowing of the isthmic portion of the aorta in the classic aortic coarctation, or even reverse blood flow across the aorta if there is an obstruction left ventricle, such as in hypoplastic left heart syndrome. So in this case, you may use color Doppler also to check not only the direction of flow, but to confirm the size or the discrepancy in size of the two ductal and aortic arch. However, the way the suspicion of aortic coarctation is raised is by looking at indirect sign and looking at the four-chamber view. This is a normal heart with balanced ventricle, and this is an abnormal heart in which there is a right ventricular prevalence, ventricular disproportion that you see here. And the right ventricle is not only larger if you look at the diameter, but also thicker. There is a degree of hypertrophy on the free wall of the right ventricle. And this is most clear sign of aortic coarctation if you look at the four-chamber view. This is a third trimester case in which, again, you have a prevalence of the right ventricle over the left ventricle, and also by inversion mode on 4D technology, you see the same type of image. Sometimes, we do not know why, in our experience, you may also have a disproportion which does not involve as much the four-chamber view, which seem quite balanced, but are only at the level of the outflow tract. This is left outflow tract, which looks normal, but then in comparison with the right outflow tract, you see there is some minor degree of disproportion, and on three-vessel view, you see that there is some disproportion as well. Again, coming back to Lindsay Allen, back in 94, but the situation is still there, it's still the same. The most severe form you can detect early in gestation because the disproportion between the two sides of the heart will be striking, so you cannot overlook that. The milder forms are consistent with the normal fetal and also especially late fetal echo. And in late pregnancy, it may be impossible to exclude coarctation categorically because it's normal that in late gestation, right heart structures become slightly enlarged in comparison with left heart structures. And here's wide experience. 3/4 of the cases had a confirmed diagnosis, and 30% of the case had an unconfirmed diagnosis. Of all the papers that you have in your CD, I just cite one, which is quite interesting to me. I think it's a Korean paper published a couple of years ago in prenatal diagnosis. And you see here they measured all the parameters in all the referral they had regarding what they call right dominant heart, which is ventricular disproportion. And you see in red, you see the actual confirmed diagnosis, and in blue, the false positive diagnosis. And what they could see is that most of the referral after 28 weeks of gestation or 30 weeks of gestation were normal and were false positive, and most of the referral they got earlier than that period were actually coarctation of the aorta, despite the fact that the diameter of what they measured was the same. So the bottom line is that in their experience, if a fetus is referred in the third trimester because of moderate ventricular disproportion and suspected aortic coarctation, there is a more than 80% chance that for that fetus to be perfectly normal. And this should be kept in mind when you counsel that patient. Another issue to be considered here is the use of 4D technology, 3D and 4D technology. So far, we have not mentioned that, but I think that also Rabbi, when speaking about abnormal venous return, will refer about these technologies. The issue is that we abandoned the longitudinal view of the aortic arch because the three neck vessels are not aligned on the same plane. So it requires a lot of skill to get the actual correct plane to get longitudinal view. If you replace a single pixel thick slice with a box across the aortic arch, no matter if you're using inversion mode, glass body or B-flow technology, you can actually get, with the longitudinal approach, all the three neck vessels, and so you can be sure that this is indeed the aortic arch, is not a ductal arch hiding behind an hypoplastic aortic arch in most of the cases. And we are looking into this. And this with their new release. And you see here that by using, for example, this glass body, you can actually see very nicely that in this case, the pulmonary artery and ductus will insert at the isthmic level of the aorta, and you see very nicely the three neck vessels and the aorta with no kinking and no shelf whatsoever here. Sorry. So this is why probably by using this type of approach, we may, there's no yet any proof in the literature, but we may improve a bit our frustrating detection rate for aortic coarctation. You see here one case we had with the shelf. This was the corresponding first chamber view. And you see here that in this case it was possible by looking at the B-flow image to see this is the right ventricle, pulmonary artery and ductus, and this is the left ventricle, aorta passing behind, ascending aorta, transverse portion of the arch, and you see again what I showed you on the multiplanar image before, that is the isthmic portion of the aorta which inserts onto the ductus, and this is the shelf rather than vice versa as it should be in case of normal heart. And of course, you do not need this type of technology to make the diagnosis of tubular hypoplasia, but again, in case of hypoplastic left heart syndrome in which there is severe involvement of the aortic arch, this is why usually the longitudinal approach may be very tricky, because this tiny arch will be hidden by the prevalence of the ductus arteriosus in front of it. And again, this is a normal longitudinal view of the aortic arch. You see no narrowing here and trivessel view here. And these are two cases of tubular hypoplasia. And you see here how nicely you see the tapering, because the arch is also hooked up if it's severely hypoplastic. And you see also that there is some persistence of blood flow in the arch after the systolic peak. And this is consistent with the so-called runoff, diastolic runoff, which is typical of severe coarctation. And so this is for the tubular form, and this is a case of shelf, in which you actually see, this is the same case I showed you before in inversion mode, and you see here the shelf. There's been also a publication, I think, by Julien regarding this issue of the diagnosis of the shelf in case of aortic coarctation. And then to finish with, I would like to briefly mention other abnormalities of the aortic arch, even though the talk by Lindsay Allen after these two talks will regard obstructions and rationale for intravenous intervention. So this is out of the talk that Lindsay Allen will deliver after my talk. We have interruption of the aortic arch. Again, it's named A, B, or C according to where the aortic arch is interrupted, if it's after the third vessel, the second vessel, or the first vessel. And you can reach your diagnosis by using grayscale ultrasound, and you can use it color Doppler sometimes, but it's difficult to get the actual orientation to see whether it's type B or type C, and this makes a difference because in type B there is a strong association, 50%, with microdeletion 22q11. If you use this type of technology, type B means that interruption is after the second neck vessel that you see here. You can make out very nicely the left ventricle, ascending aorta, two neck vessels, and then there is interruption of the arch. And behind you have the ductus arteriosus. So by using this type of approach, all these aortic arch abnormalities are much more straightforward diagnosed than before, of course, in the setting of fetal echo and not in the setting of the screening. It goes without saying. Also, coming back to the right aortic arch, this is how you can detect it by using color Doppler. This is a normal arch, and this is in comparison with the right aortic arch, in which the trachea is in the middle of the two arches, the ductal and the aortic arch here. And in this case, you can use 4D technology just to study the branching pattern of the neck vessels. And also to confirm diagnosis of such difficult cases of double aortic arch. Here you see the view. This is ductal arch. This is the ascending aorta just bifurcating in front of the trachea in two branches. These are the two aortic arches. Usually one of the two branches is severely hypoplastic. In this case was not so much hypoplastic, but there was some discrepancy in sides. You see here. And this is how you can have a look at by using B-flow. Left ventricle, one arch, second arch. And here you have the pulmonary artery and ductus and the two arches meeting at the level of the ductus. And then aberrant tripsicleven artery, described by Rabi in 2005 in association with Down syndrome and congenital heart disease. Again, this is how you diagnose it by using your power Doppler or color Doppler. You have to reduce the PRF, have a good orientation, not with the two vessels, this is the difficult thing, but with the lateral approach, because the vessel goes behind the trachea that you see here. This is the drawing. And you can use B-flow not only to confirm it, but especially to have a look frontally, and you see why it is called aberrant, because it goes behind the arch, and this is quite similar in appearance to what you see in this drawing here. And to finish with why these abnormalities are important, because they can create the so-called retrotracheal sling in comparison with the normal arch. You see here, in case of right aortic arch, or also in some cases of aberrant rapsiclavian artery, you may actually have this sling behind the trachea, and both the trachea and the esophagus become entrapped into the two branches, and so you may have esophageal or tracheal compression responsible for symptoms such as early dyspnea or wheezing and vomiting. In some of these cases need a very simple early intervention. But this is way how to diagnose it and what is the importance of these abnormalities. So in conclusion, for aortic arch and coarctation, all these anomalies can be diagnosed by color Doppler and grayscale ultrasound. Coarctation is indeed still the major cause and major diagnosis, creating both false positive and false negative diagnosis at the same time. This is quite important also because in some of these cases there will be a need for an early intervention. So if you raise a suspicion of aortic coarctation, even though there are few chances that there is indeed a coarctation in that single case, but we can speak about this in the discussion afterwards, it is the case to centralize that baby into the referral center, because if it happens to be a coarctation, it will be saved by delivering in the referral center, because in some cases you need an early intervention. And also pediatric cardiologists will tell you, and Lindsay and Jolene will tell you, that in some cases also coarctation will be discharged in second, third day of life and come back acutely afterwards, because also expert pediatric cardiologists may miss a coarctation also during the first days of life. So you can reach diagnosis with some challenging points in this type of abnormalities. The assessment of the aortic arch and its branching pattern is difficult sometimes, but 4D technology is a major asset in this case and will help you in reaching this kind of diagnosis. And thank you for your attention.